Welcome to the Deep Dive, the place where we take complex, systematic knowledge and transform it into clear, essential understanding.
Today, we're undertaking a really critical deep dive into a topic that is just foundational to surgical diagnosis.
We're talking about the comprehensive, structured, clinical examination of the breast.
Right. This is the first, and you could argue the most vital step in detecting breast pathology. And, for the listener, the central paradox here is the hook.
What's that?
The vast majority of serious breast diseases, especially carcinoma, often present with the patient complaining of a simple, and this is the key word, a painless lump.
That distinction, painless versus painful, is so counterintuitive, isn't it? When people think about a serious disease, they automatically associate it with pain.
They do, and that's why the presentation is so deceptively simple. It requires an incredibly rigorous, a systematic search for very subtle signs. You just can't rely on symptoms alone.
Absolutely not. So that's our focus today, right?
Exactly.
A highly structured, step-by-step methodology used by expert clinicians.
Exactly. And our source material for this details that precise process. We're specifically highlighting the structured approach detailed by Dr. Senthil Kumaran, who is an associate professor of surgery at AIIMS Nagpur.
So our mission today is to give you a kind of shortcut, a guide to understanding the systematic choreography of this examination.
Right.
We're going to break down all the stages, from taking the history to the 4 different inspection positions, all the way to those critical palpation techniques, and turn it all into clear, understandable insights.
And you'll see how these seemingly simple steps can turn what feels like overwhelming information into really precise diagnostic conclusions.
Okay, so where do we begin?
We begin where every single diagnostic journey begins.
Mm.
The history. A thorough history is like our internal GPS. It guides the whole physical examination. And honestly, it often lets us establish a strong working hypothesis before we even ask the patient to disrobe.
So we have a patient who's come in reporting a lump. Before anything else, what's the first data point that immediately frames your thinking?
Age, without a doubt. Age provides immediate context and helps us narrow the field of possibilities right away.
Okay, so walk me through that. Let's say we have a younger patient.
If we're examining a patient, typically under 35 years old, the prime consideration is a fibroadenoma. That's the classic benign tumor of the young adult breast.
And as we move into middle age,
As we move into middle age, we often start to see fibroadenosis, which is sometimes called mammary dysplasia. It's characterized more by a general sort of nodularity.
and then the big concern, carcinoma. What's the typical age range there?
Carcinoma is typically found in patients over 40 years old. But, and this is a really crucial teaching point, age should never be used to completely exclude carcinoma. We have to remain vigilant even in younger populations.
And I guess age can point to other things too, right? Not just tumors.
Oh, absolutely. It helps us identify inflammatory conditions. For instance, an intramammary abscess, or what we call mastitis of lactation, is overwhelmingly common in young breastfeeding women. So age is our first filter.
Okay, so we've got the age context. Now we have to interrogate the lump itself. You mentioned the trio of onset, duration, and rate of growth.
Yes. So if a lump has been there for years and it's growing very slowly, that sounds reassuring.
Generally, it is. A long history coupled with very slow growth is highly suggestive of a benign process, like fibroadenosis or a fibroadenoma. The benign process usually takes its time.
But on the flip side, a short history is a red flag.
A huge red flag.
Huge.
The moment we hear a short history, say a few months, and a fast, aggressive rate of growth, the alarm bells immediately start ringing for carcinoma. But I imagine there are always exceptions that keep clinicians on their toes.
Always. The main exception to that fast growth rule is something called atrophic serous carcinoma. This is a particularly fibrous, tough cancer that can actually be quite slow growing.
So it can present with a much longer history.
It can, sometimes over a year or more. And that's why consistency, which we'll get into later during palpation, is so important. You can't just rely on the rate of growth alone.
You mentioned a difficult statistic about the lag time in diagnosis.
It's a sobering reality, and it's often cited in the literature. There is, on average, about a 6-week lag period between the time a patient first discovers a carcinoma lump themselves and the moment they actually seek professional medical advice.
6 weeks.
And those 6 weeks are critical. It just underscores why systematic screening and self-awareness are so important. Early detection really hinges on closing that time gap.
Let's talk about trauma for a second. It seems so common for patients to associate finding a lump with a recent bump or an injury. Is trauma a genuine cause?
It's a very common story, but trauma is rarely, if ever, a direct cause of malignancy.
So what's happening then?
Trauma really does two things. One, it can cause a local hematoma, or more commonly, something called fat necrosis, which presents as a hard, sometimes tender lump. But more often, trauma acts as an unmasking event.
An unmasking event.
Yes. The patient gets a minor injury, they start palpating the area because it's a bit tender, and then they discover a pre-existing lump that was already there, but they just hadn't noticed it before.
So the history has to carefully distinguish between the time of the injury and the true onset of the lesion.
Precisely. Now let's go back to pain. If carcinoma is typically painless, what is the significance when a patient's main complaint is pain?
That immediately shifts our diagnostic focus, doesn't it?
It does. It shifts it away from early, straightforward carcinoma. Intense, throbbing pain, often accompanied by feeling generally unwell. That's the hallmark of acute mastitis, a severe inflammation or an abscess with pus formation.
Okay, and what about the more common, less acute type of pain?
That would be cyclical pain. Pain that gets worse in the premenstrual or menstrual phase is the classic feature of fibroadenosis. It's often in both breasts, it's diffuse, and it's all related to hormonal fluctuation.
So paradoxically, the presence of significant cyclical pain is usually a strong indicator that the underlying problem is actually benign.
In many cases, yes. It's usually a strong indicator for benign fibroadenosis.
Moving on from the lump and pain, the nipple itself can offer a wealth of clues. Let's talk about discharge. When is discharge concerning?
Discharge demands immediate attention. We have to categorize it by its nature. If the discharge is bloody, whether it's fresh or altered, kind of brownish, that immediately suggests a serious intraductal pathology.
Like what?
It could be a duct papilloma, which is a common cause of bloody discharge, or, more ominously, a carcinoma. Pus obviously points to an abscess.
What about other types of discharge, greenish or clear?
Serous, which is clear or yellowish or greenish discharge, is much more commonly linked to benign processes like ductectasia or fibroadenosis, so the color is a huge clue.
And what about the physical position of the nipple, specifically retraction? How can you tell if nipple retraction is a new serious sign or just a developmental quirk someone's had their whole life?
We need precise historical context. If the patient says, oh, my nipple has been retracted since I was a teenager, or for as long as I can remember, it's almost certainly developmental or congenital, not pathological.
But recent retraction is a different story.
A completely different story. If the patient reports that the nipple has recently started to pull inward, that is highly significant. It suggests an underlying fibrosis is pulling the duct system inwards, which is very characteristic of carcinoma or sometimes chronic inflammation.
Okay, so finally, in the history, we had to connect this local problem to the entire patient, systemic symptoms and risk factors.
Correct. We have to ask about general health, particularly unexplained loss of weight, which is a frequent complaint in advanced carcinoma or in less common conditions like tuberculosis of the breast.
And personal history.
Personal history must cover menstrual and lactational history. We know that fibroadenosis and carcinoma are more often noted in unmarried women, nulliparous women, or those who haven't breastfed.
And the family tree itself, that's a huge one.
A huge one. We have to probe deep for family history, especially in first-degree relatives, so mother, grandmother, sisters who have had carcinoma. Breast diseases, particularly carcinoma, are well known to run in families.
So establishing that genetic or familial link is the final piece of historical evidence that raises your index of suspicion before the physical exam even begins.
Exactly. This whole rigorous history-taking process ensures that when we start the physical exam, we already have a focused, evidence-based roadmap.
We've built our hypothesis based on the patient's story. Now we transition into the physical examination, which Dr. Kumaran emphasizes must be systematic, not just a random check.
It has to be. The preparation itself seems straightforward, but it's foundational.
What's non-negotiable?
The patient has to be completely stripped to the waist. We need to see the entire breast, the axilla, the supraclavicular regions, everything. And adequate privacy and warmth are essential so the patient can relax.
And lighting is key, I imagine.
Absolutely mandatory. You need excellent tangential lighting to spot those early skin changes like dimpling or puckering that you might miss otherwise.
And the patient's position isn't static. You mentioned we're essentially putting the breast through a series of stress tests using gravity and muscle contraction, moving through 4 key views.
Exactly. We're changing the mechanical tension on the breast tissue to bring out any hidden signs of fixation. The first is the sitting posture,
The baseline.
the baseline for inspection. It lets us compare the breasts easily, check nipple levels, and it's the main position for palpating the axillary nodes later on.
Then the semi-recumbent position.
Semi-recumbent at about 35 degrees, it's a good transitional position. Then fully recumbent, lying flat, which is crucial for deep palpation because it spreads the breast tissue out across the chest wall.
And the fourth one you said is key for revealing deep issues.
The bending forward position. This is the key diagnostic position for revealing deep fibrosis or fixation.
Okay, let's walk through the inspection, always comparing both sides. We start with position 1, arms by the side. What are we looking for?
We're assessing basic symmetry. Overall size, shape, position. Is there a congenital asymmetry? Is there an obvious mass displacing the contour? And we compare the level of the nipples, looking for any immediate displacement that might suggest an underlying mass is pulling the tissue.
Next, we ask them to raise their arms straight above their head. Position 2. Why is this maneuver so effective?
Because raising the arms stretches the pectoral fascia and the suspensory ligaments. We call them Astley-Cooper's ligaments. If there's a tumor that's fixed deeply, this action pulls on those structures.
And that makes things more obvious.
Far more obvious. It accentuates subtle lumps or dimples, and crucially, it often makes the upward elevation of a nipple, which is characteristic of carcinoma, much more prominent. We're stress testing the internal structures.
Position 3 involves active muscle use. Hands on hips, pressing and relaxing.
This is a direct test of the pectoralis major muscle. When the patient presses their hands hard against their hips, they tense that muscle. If a mass is fixed to the fascia or the muscle itself, this tension will immediately make any abnormal nipple movement or skin dimpling dramatically more evident.
So you're looking for visible proof of fixation to the chest wall muscles.
That's it. And finally, the bending forward technique position 4. You said this is the most critical visual check for retraction.
Why is it the ultimate visual proof?
Because when the patient bends forward from the waist, gravity should cause both breasts to fall away equally from the chest wall, moving pendulously. But if there's a rigid, infiltrating tumor deep within the breast, the fibrosis will hold that segment of the breast and the nipple firmly against the chest wall.
So one side will just stay put.
The affected side will fail to fall away. It creates a noticeable visual difference compared to the healthy side. This is visual confirmation of abnormal fibrosis, and that often means carcinoma.
I never realized how much mechanical choreography goes into just looking at the breasts. Let's delve into the specific visible signs we're looking for on the skin. The first is puckering or dimpling.
Puckering, or tethering, is a visible sign of tension. It's often seen in serous carcinoma, where the tumor causes the breast to contract and pull inward. This happens because the invading cancer contracts those Cooper's ligaments, pulling the skin down.
Is there a way to make it more obvious?
Yes, clinicians will sometimes gently lift the breast upwards to accentuate this dimpling and confirm it.
And the classic, highly specific sign of more advanced disease? Peau d'orange, the orange peel appearance.
Peau d'orange is what we call pathognomonic for lymphatic blockage. It happens when the tumor blocks the subcutaneous lymphatics, leading to massive edema or swelling of the skin.
So why the pitted orange peel look?
Because the openings of the sweat glands and hair follicles are fixed to the deep fascia by ligaments. So the swelling occurs everywhere but at those fixed points. This deepens the fixed points and creates that texture. It indicates advanced lymphatic involvement.
We also have to look at the veins, right? Engorged vein.
Yes, engorged superficial veins usually mean there's a rapidly growing mass that's demanding a large blood supply. We commonly see this in aggressive benign tumors, like a large fibroadenoma, what's called a cystosarcoma phalloides, or in rapidly growing sarcomas.
Let's focus back on the nipple and areola during inspection.
Yeah.
You have to be able to spot Paget's disease and not confuse it with simple eczema.
This differentiation is essential. Eczema is usually bilateral. It tends to be itchy. You might see small blisters or vesicles. And crucially, the nipple itself remains structurally intact.
And Paget's disease.
Paget's disease, which is a malignant condition, is characterized by nipple destruction. It presents as a flat, red, weeping ulcer, and it is almost always unilateral, one side only. If you see unilateral, ulcerative destruction of the nipple, you have to assume Paget's until proven otherwise.
And finally, we quickly scan the arm and the rest of the thorax. What are the really ominous signs of widespread local invasion?
We look for two things. First, cancer en cuirasse, which translates to cancer in armor. It's multiple cancerous nodules and thickened, infiltrated skin spreading across the chest wall, giving it a tough, armor-like feel.
And the second?
Brawny edema of the arm. This suggests major lymphatic blockage and extensive neoplastic infiltration of the axillary lymph nodes, causing the entire arm to become swollen and hard. These signs indicate late-stage, locally advanced disease.
We've thoroughly inspected the patient in motion and at rest. Now we move to palpation, which feels like the final defining moment for characterizing the mass.
It really is. We get the patient into that semi-recumbent position, pillow under the scapula, and the fundamental principle before you even touch the affected side is
Palpate the normal breast first.
always. This allows you to get a feel for that woman's natural glandular consistency, which can feel quite lumpy on its own. It establishes a baseline so you don't mistake normal nodularity for pathology.
Now for what I found to be the most fascinating part of this methodology, the technique of palpation. We're told to use the flat of the hand, not the sensitive fingertips. Why this diagnostic paradox?
This is the absolute core of the clinical breast exam. Palpation has to be done using the palmar surface of the fingers with the hand flat against the breast. And yes, you're right, the flat of the hand is purposely the less sensitive method.
But why? Why would you intentionally reduce your sensitivity when you're searching for a small lump?
Because your highly sensitive fingertips are prone to feeling all the soft, ill-defined, benign nodularity of fibroadenosis.
Yeah.
And that can really confuse the diagnosis.
So you're filtering out the noise.
You're filtering out the benign noise. By using the flat of the hand, this reduced sensitivity allows you to isolate the one defining physical characteristic of the most dangerous pathology: the stony, hard consistency of carcinoma. If the flat hand can detect it, you know it's significant.
That's brilliant. You use reduced sensitivity to increase specificity. So once we're using this flat hand approach, how do we search systematically?
We use a systematic sweep. We cover the 4 quadrants, we make sure to examine the axillary tail, that little bit of breast tissue that goes up toward the armpit, and critically, we have to palpate the area just behind the nipple.
The commonly missed spot.
Very easily missed. We use the flat fingers to palpate either concentrically, in circles, or in a radial pattern, like spokes on a wheel, covering every millimeter of breast tissue against the fixed chest wall.
If we detect a lump, we have to characterize it fully. Let's run the comparison between the classic benign lump and a carcinoma using shape, margin, and consistency.
This is where we distinguish the breast mouse from the infiltrating tumor. For a benign fibroadenoma, the shape is globular and regular. A carcinoma is uneven and irregular.
And the surface.
A fibroadenoma is smooth, almost like a marble. A carcinoma is uneven, knobby. The margin of a fibroadenoma is well-defined, but a carcinoma's margin is irregular and indistinct. It just sort of bleeds into the surrounding tissue.
And the 2 most important features, consistency and mobility.
The fibroadenoma is firm, elastic, maybe a bit rubbery. The carcinoma is stony hard, like a pebble. And for mobility, the fibroadenoma is highly mobile. It slips away from your fingers.
The breast mouse. It's such a memorable term. The idea that a fibroadenoma slips away, that it's mobile, is our best friend in clinical assessment.
It absolutely is. Mobility is a strong indicator of being encapsulated and benign. The most telling feature of a carcinoma is that inability to move the lump independently of the surrounding tissue, coupled with that uncompromising stony hardness.
But wait, before we lock that diagnosis in, we have to rule out the possibility of fluid, right? What if it's a cyst?
Exactly. Even a very tense cyst can feel hard. So we move to special tests. Fluctuation is performed to see if the lump is cystic. You support the lump with one hand and tap the center with the index finger of the other, feeling for the impulse of fluid.
And transillumination.
We use transillumination in a dark room. Solid tumors are opaque. They block light completely. A simple cyst or an area of fat might be translucent.
Okay, now we arrive at the most crucial diagnostic sequence. The fixity tests. This is the make-or-break assessment for malignancy, isn't it? We start with the skin.
Yes, fixity to the skin indicates infiltration. We define it in 2 stages. First is tethering. This is early infiltration.
How do you test for that?
You move the lump from side to side. Because the tumor has started to invade the Cooper's ligaments, moving the mass pulls on the skin at the extremes of movement, causing that visible puckering or dimpling. The skin is tethered down.
And the second stage.
Fixed to the skin. This is late infiltration. The skin over the lump is completely attached. You can't move the skin over the lump, and you certainly can't pinch it up. This indicates direct invasion.
Once we've established the relationship with the skin, we check fixity to the breast tissue itself again.
We confirm that mobility check. We hold the breast gently with one hand and try to move the tumor with the other. The fibroadenoma moves freely within the breast. The carcinoma is fixed to the surrounding glandular tissue. It moves only when the breast moves.
Okay, the third test. Fixity to the underlying pectoralis major muscle. This is where the mechanics get a bit more complex.
Right. This test is essential because it determines if the cancer has broken through the deep fascia and invaded the muscle.
Walk us through the procedure.
First, the patient sits and places their hand lightly on their hip. The muscle is relaxed. We move the lump to assess its baseline mobility. Then, the patient is asked to press their hand down on their hip hard.
To make the muscle taut.
Exactly. This forces the pectoralis major into maximum tension. It becomes an immobile anchor. Now, we try to move the lump again.
And what happens if it's fixed?
If the lump is fixed to the pectoral fascia or the muscle, its mobility will be severely restricted, or maybe it won't move at all when the muscle is contracted. If it still moves freely, it's not fixed to the pectoral structure.
That makes perfect sense. What if the lump is in the lower or outer part of the breast? It could be fixed to a different muscle.
Right. It could be fixed to the serratus anterior. To test that, we ask the patient to stand and push their affected arm against a wall, contracting that muscle. We then repalpate the lump. If the mobility is restricted then, it confirms fixity to the serratus anterior.
And finally, the worst case scenario, fixity to the chest wall.
This is the most severe finding. If the tumor is immobile, completely fixed, regardless of whether the muscles are contracted or relaxed, then the tumor has invaded through all the layers and is fixed directly to the underlying ribs.
After all these fixation checks, we finish the local palpation by examining the nipple area itself.
We gently palpate the tissue deep to the nipple. If the lump is central, moving it might accentuate any nipple retraction. And if the nipple is retracted, we try to avert it by pressing gently on the areola from both sides.
Why do that?
If the retraction is due to carcinoma, the fibrosis will prevent aphasia. It's stuck. If it's congenital, it might still pop out. And of course, we note any discharge that's expressed during this.
We fully characterize the mass locally. Now we pivot to regional spread. For cancer staging and prognosis, the lymph node examination is arguably as critical as finding the lump itself.
It is. Precision is key here. We examine the lymph nodes with the patient sitting, muscles relaxed. We have to meticulously palpate all 5 major groups of axillary nodes, plus the supraclavicular area.
Let's start with the pectoral group, the most common site of initial spread.
Right. 1. The pectoral group in the anterior axillary fold. The patient's arm is slightly abducted. We slide our fingers high up and behind the border of the pectoralis major muscle. Then the patient's arm rests on our forearm to relax the muscle further.
Okay, moving laterally.
2. The brachial group on the lateral wall. These nodes are high up on the inner aspect of the humerus. We palpate them firmly against the bone itself.
Then we have to check the back of the armpit.
3. The subscapular group in the posterior axillary fold. For these, we usually stand behind the patient, feeling the nodes against the subscapularis muscle.
Now for the central and apical groups, which are often the hardest to access.
They are. 4. The central group is in the mid-axilla. We put our fingers high up into the apex of the axilla, pointing towards the lateral chest wall. Then the patient brings their arm gently to their side, which helps trap the nodes between our fingers and the ribs.
And the apical group, which sits highest.
5. The apical group is examined similarly, but you have to push your fingers even further up, right into the apex. Finding hard, fixed nodes here is extremely concerning because they're just below the clavipectoral fascia. If you can feel them, it suggests a significant tumor burden.
And we can't forget the drainage further up toward the neck.
Absolutely not. We conclude the regional survey by examining the supraclavicular and infraclavicular nodes. The examiner stands behind the patient, dips their fingers deep into the hollow just above the middle of the clavicle. Both sides have to be palpated and compared at the same time.
And what defines malignancy in these nodes?
We note the number and size, but the 2 most critical features are consistency and mobility. Hard, shoddy nodes are highly suspicious. But the most sinister sign is fixity. Fixed nodes that are matted together or stuck to the underlying muscle, are a poor prognostic sign.
After the local and regional assessment, the final stage is the general survey, a systematic search for remote metastasis. Where do we look?
Breast cancer classically metastasizes via the blood to predictable sites, so we check those. First, the bones.
The most common site.
One of the most common. We palpate the easily accessible sites, the sternum, ribs, spine, and the upper ends of the humerus and femur. Any localized tenderness is highly concerning. Then the liver.
A simple abdominal palpation.
Yes, to check for an enlarged liver or nodular deposits, then a basic lung examination, and finally one that is often overlooked, the pelvis,
The pelvis. How does it get there?
through lymphatic drainage or transcolomic implantation. So a complete examination must include a rectal and vaginal examination to check for secondary ovarian deposits, known as a Krukenberg's tumor.
So the systematic clinical exam finishes with a full body assessment, following all the tumor's potential escape routes.
With the history complete, the inspection refined, the lump characterized, and the regional and distant sites checked, the clinician can now confidently narrow down the differential diagnosis. The physical findings give you 90% of the answer.
Let's summarize those critical differentiators once more, focusing on what you feel.
Okay. The clinical distinctions are sharp. Fibroadenoma, the breast mouse, highly mobile, solitary, smooth, firm, but elastic, classic in young women.
Then fibroadenosis.
Fibroadenosis, or ANDI. This is more diffuse, often bilateral nodularity with cyclical tenderness. The lumps can fluctuate in size, and they lack that stony hardness of cancer.
And finally, carcinoma.
Carcinoma, serous type. Painless, stony hard, irregular margins, and critically, fixed to surrounding tissues, the skin, the breast substance, or the underlying muscle.
And a quick note on the male breast, gynecomastia.
It's important to differentiate from male breast cancer, which is rare but very serious. Gynecomastia is just an increase of ductal and connective tissue. It presents as a firm subareolar disc of tissue. It needs to be clearly distinguished from a fixed, hard, eccentric malignancy.
Once the clinical suspicion is established, we move to investigations to confirm or clarify. If we strongly suspect a fluid-filled cyst, where do we start?
We use aspiration. This can be both diagnostic and therapeutic for simple cysts, but we have to follow 4 strict criteria for it to be considered definitively benign.
Okay, what are they?
1, the fluid can't be bloodstained. 2, the cyst must disappear completely after aspiration. 3, it must not rapidly refill. And 4, the cytology of the fluid must be negative for malignant cells.
If any of those 4 fail, the simple cyst diagnosis is thrown out.
Correct. And we have to proceed to imaging or biopsy. The standard routine imaging is mammography. It's essential and highly reliable, particularly in postmenopausal women whose breasts have more fatty tissue.
What does a malignant lesion look like on a mammogram?
It often appears as a spiculated mass, an irregular star-shaped formation, and it can show clusters of fine micropalsifications, along with that architectural distortion we talked about.
But mammography isn't perfect for everyone, right? What about in younger women?
That's its main limitation. In younger, premenopausal women, the breasts are often extremely dense with glandular tissue. This dense tissue appears white on a mammogram, and it can effectively mask small tumors.
Which is where ultrasound comes in.
Precisely. Ultrasound is invaluable in dense breasts because it can clearly differentiate between a solid mass and a cystic, fluid-filled one. It's key when the mammogram is ambiguous due to that density.
And ultimately, for any solid mass where malignancy is still a possibility, we need tissue.
The final court of appeal is always biopsy. Whether it's a fine needle aspiration, a core needle biopsy, or an excision biopsy where the whole lump is removed, a tissue diagnosis is mandatory to define the exact type and grade of cancer.
Finally, we revisit that systemic search for spread, but with imaging.
Right. After a routine chest x-ray, the most sensitive investigation for skeletal spread is the bone scan. It can spot metastases far earlier than conventional x-rays. For the abdomen, we'd use a liver scan or a CT scan. These investigations finalize the clinical staging that was started with the physical exam.
What a detailed, meticulous process. This deep dive, grounded in the systematic surgical methodology highlighted by Dr. Senthil Kumaran, really shows that the clinical breast examination is a structured art form.
It is. It's about putting the breast under mechanical stress with those 4 positions, and then using that, as you called it, the diagnostic paradox of the flat hand technique, to isolate that singular, stony hard sign of malignancy.
And that's the true power. It's transforming a vague lump into objective, measurable signs of fixation or mobility. I'll never forget the breast mouse.
A mobile, smooth mass versus the fixed, irregular, stony hard carcinoma. Those fixity tests are the critical indicators that guide everything that comes next. The clinical examination remains the indispensable cornerstone.
It is the foundation. Advanced imaging refines the picture, but it's the initial, careful groundwork of inspection and palpation that points the clinician in the right direction.
Indeed. That systematic search for subtle signs is what saves lives.
As we conclude, let's revisit a provocative finding from the source material. The prognosis of breast carcinoma is often noted to be better when the onset is within 5 years of menopause, but it's demonstrably worse in younger patients.
Right.
So, given that the age overlap between serious malignancy and benign, lumpy conditions is so significant, and given the complexity of these methods we've discussed, how might increasing public awareness of these detailed diagnostic steps, not just feel for a lump, but understanding the significance of painlessness, of fixation, of texture, how might that shift our whole societal approach and maybe close that 6-week lag time?
It raises a crucial question, doesn't it? It's about translating professional rigor into public knowledge. The more informed a patient is about what defines a truly worrisome finding, the more empowered they are to act immediately and, just as importantly, to ensure they receive this level of systematic, meticulous examination when they do seek help.
A profound point for you to mull over. That's it for this deep dive into the systematic clinical examination. Thank you for joining us.
Until next time.